Welcome everyone to the kickoff of our third Ontario West Midwifery Conference. We have an absolutely incredible agenda and we are so happy you could join us again this year. We are pleased to have over 180 conference registrants from Ontario, across Canada, North America, and even some international registrants from around the world. The inspiration for this conference was to highlight the amazing work of Ontario midwives and to showcase some of the work that our department is doing. We are hoping to leave participants feeling inspired to take next steps within the realms of research, innovative clinical programs, and/or midwifery research, or leadership, excuse me. This is day one of 3 days, where each day we will be highlighting a theme. Today we are showcasing sessions related to advancing midwifery research. My name is Rebecca Thompson. I am the Midwifery Executive Lead for the Department of Midwifery at London Health Sciences Centre and your host for today's session. My co-host will be Megan Furnival, the LHSC Midwifery Department Research Lead. We would like to start off the conference with a land acknowledgement. We acknowledge that this is sacred land upon which we are privileged to live and work. We recognize the deep connection and the long-standing relationship between Indigenous people and the land of Southwest Ontario and of London. This land has supported human beings for at least the past 10,000 years and is the traditional territory of the Anishinaabe, which includes the Ojibwe or Chippewa Nation, the Haudenosaunee, also known as the Iroquois, which includes the Oneida Nation, the Attawandaran, also known as the Neutral, and the Wendat people. We are deeply grateful to have the opportunity to be in this place. We acknowledge that this is just the beginning of a process, and we commit to a continued journey of listening, learning, and building relationships to finding truth and reconciliation, and collaborating on 3 major projects that Indigenous midwives stated would improve their ability to provide culturally appropriate care and to be incorporated into the hospital environment, as per the Truth and Reconciliation Commission's calls to action 22 and 23. Some small housekeeping notes before we begin. All participants' Zoom audio and video should remain off during the presentation. All presentations are being recorded. In order to save time, I will have a brief introduction for each speaker, and we will include their full bios in the comments. At the end of the speaker's presentation, there will be 5 to 10 minutes for questions, time permitting. Please type any questions in the Zoom Q&A box for me to read, and our presenter panelists will answer either live or in the Q&A box following their presentation. We will be keeping time, and I will turn my camera on with 1 minute left to presenters to know the time limit is almost finished. Finally, please complete our post-conference feedback survey that will be posted as a QR code at the end of the conference day each day. We, of course, always welcome feedback, and you can email feedback to any of the hosts at the emails provided at the end of each conference day. You will receive a certificate of attendance, and our conference is recorded and will be posted on our LHSC Department of Midwifery website. Okay, now let's get to the exciting presentations we have for all of you today. Today's first LHSC Research Spotlight is titled Home Phototherapy, Canada-Wide Survey Results on Parental Perspectives by Lauren Columbus. Lauren is the Academic Practice Lead with the LHSC Department of Midwifery and a registered midwife with the TIME program Expanded Midwifery Care Model at London Health Sciences Centre. Lauren, you may now share your screen.
All right, I hope that's working. I'm not sure. We'll give it a try there. Does that work?
That looks perfect.
Okay, great. Thank you so much. And thanks for having me today, everyone. I'm happy to share the results from our Canada-wide survey on parental perspectives on home phototherapy. I just want to also thank Dr. Fatma Al-Rashdi, who was the lead on this project, but who is working in the pediatric eMERGE and couldn't be here today. Just to provide a little bit of context and background, as you all know, a large percentage of newborns will develop neonatal hyperbilirubinemia, but around 2 to 3% will require treatment. It's the most common reason for hospitalization in infants aged less than 10 days here in Canada, and the current standard treatment in Canada involves phototherapy administered in a hospital setting. There have been recent advancements in technology that have led to the development of portable and compact options like fiber optic phototherapy systems, or FPSs, which resemble blankets or cocoons as opposed to the traditional overhead lights that are tied to isolates. It's these types of technological advancements that have revolutionized phototherapy and have now offered a simple, portable, or efficient option for patients and their families that generally provide fewer barriers to supporting the mother-infant dyad, promoting bonding, and protecting parent-infant relationships. It's these changes in technologies, along with recent changes in the American Academy of Pediatric guidelines, that have paved the way for the possibility of home-based phototherapy. In terms of what the guidelines actually say, the most recent change in 2022 in the AAP CPG shifted their language to now support home-based LED phototherapy treatment for infants who meet a generally low-risk criteria. This was a big departure from previous guidelines and a really welcome change for a lot of families. The criteria is fairly conservative, but generally involves infants who are greater than 38 weeks with no known hyperbilirubinemia toxicity factors. The reason we quote the AAP is just because the Canadian Pediatric Society hyperbilirubinemia guideline is quite outdated, last published in 2007. We've heard from colleagues that the update should be coming sort of sometime soon in the next year, and that it's likely to mirror the AAP and the recommendations as well as thresholds. And we sincerely hope that there'll be an inclusion of a recommendation and support for home phototherapy. I'm not going to dive too much into the background, but I just wanted to note that there have been very rigorous RCTs that have come out in the last couple of years that have evaluated the safety and effectiveness of home phototherapy. That's always everybody's first question, is just, does this work? These RCTs have largely been based on home photo programs in Europe and Australia. And across all of the studies, there has been no difference generally in duration or success of treatment, no critical incidents, and no exchange transfusions needed. There have also been some published studies on the cost effectiveness of home phototherapy. And I'm just going to point out these two that were done in Denmark and in Australia that showed very significant cost savings to HPT versus inpatient phototherapy. 71% in the study in Europe, and a reduction in cost from 640 Australian dollars per day for HPT compared to the standard 2,100 per day for IPT. So as you can see, these are fairly significant cost savings. But also from an excellent study also done in Denmark on the parental experiences of home phototherapy. This is also something that parents have really enjoyed. And so it's both a cost savings and generally has very high parent satisfaction. Parents felt secure at home with their infants, and they emphasized the importance of around-the-clock access to hospital staff and the provision of very clear information. Our study that we conducted here, our primary goal was to assess Canadian parental interest in home phototherapy, knowing that there has been excellent research out there to support this program around the world, but that we really wanted to explore these options within Canada in the hopes that having data gathered within our own country could provide healthcare workers, policymakers, people who make decisions on this type of programming, really valuable access to Canadian parent perspectives, and just whether this is an option that parents actually want in the Canadian context or not. Our secondary objectives for this study were to also dive into some of the support mechanisms and resources that parents would feel that they would need, operational instructions, preferences for how their follow-up care would look. And we also wanted to look at the relationship between socioeconomic status, racialized status, and the decisions of parents to choose home photo as an option, and whether there were any relationship between some of these demographic factors. The study design was a cross-sectional survey, and the inclusion criteria was just that you had to have had a child who was treated for hyperbili in Canada in the last 5 years. The survey was shared online, publicly available across mostly social media platforms as per our REB stipulations. And we did do a sample size calculation to adequately and properly power this study, which meant we needed 357 fully completed surveys. We are so very close to that. And so the results that I'm presenting today are just slightly under this powered number, but we're hoping that we can gather the last, I think, 19 remaining surveys that we need to get this wrapped up. We also provided the descriptive data, which I'll go through, and a thematic analysis of the open-ended survey responses. So just to quickly summarize, the survey's been open for most of this year. We are at 338 valid responses and just several who responses remained incomplete. The vast majority had phototherapy in the hospital. And as you can see, again, we have representation across most of the country, with the largest proportion being from here in Ontario. In terms of the primary objective of just asking, is this something that you would have considered? We provided a photo of a fiber optic phototherapy system, a brief description of HPT, and asked if they would have considered it. The respondents were then given an open-ended text box to describe why they would choose yes or no. As you can see from the results here, 88% had said that they would have considered home phototherapy, with only 6% saying that they would not have. In terms of our correlation test, these were based on 4 demographic questions. So we did ask about people's location, their education level for the birthing parent, their income, as well as whether they consider themselves to be a visible minority. In terms of the results of this study population, it is a very highly educated as well as high income population that we reached with this survey. And so you can see 94% hold a college or university degree. Almost half had a median income of more than 150,000, and 17% considered themselves to be a visible minority compared to the 26% Canadian percentage for people who identify as racialized. However, in terms of the results for these 4 demographic questions, as they related to whether a parent considered HPT or not, we actually had no significant relation between any of those. So it didn't seem to impact whether people, where people's location was, their level of education, or their income or minority status as to whether or not they would consider HPT. And I think this is a really important question to have answered in terms of considering, criteria and whether or not different populations will require different things in terms of education and support. When it comes to the actual analysis of the thematic analysis of our open-ended survey results, our results supported a model of suitability of home phototherapy that you'll see pictured here. So this included 3 sort of key areas, which involved having a supportive home environment, as well as anytime access to your healthcare provider for questions and TSBs, and then the capacity for compliance. So we'll just dive into these a little bit here. The supportive home environment ultimately came up frequently, both as an enabler for parents who responded that they would consider HPT, but it was also a detractor for those who said that they would not. Many respondents listed having access to more support when they were in home than in hospital, often because they felt like they'd had to split up their resources across 2 locations. One parent stays at home with the kids, the other goes into the hospital with the newborn. So this is really predicated on the lived realities of the respondents, that they must have been from 2-parent families or had really good community support and childcare available, food access, safe homes, things like that. The 24/7 access to HCPs for questions, concerns, and in-home TSBs were also a very significant factor. This was emphasized both in our qualitative responses as well as our quantitative responses. And lastly, the capacity for compliance was a really interesting factor. Those in favor of HPT really felt that they had more than enough capacity for compliance to deliver HPT, while those who responded no had generally expressed theoretical concerns about the population's ability to comply with it. So we'll get to that in a moment. In terms of the sort of themes that came out of the yes, why responses, we felt that the model was supported by a few themes here. Parents endorsed that they would be having phototherapy at home would be less stressful. They also described the simplicity of the technology and that they would have better recovery at home. The vast majority of responses that focused on reduced parental stress levels with home photo focused on the logistics of having older children, pets, travel, separation from their family, trips back and forth, and that just the hospital setting, generally speaking, created an overall higher level of anxiety for these participants. In terms of our second category, it was really the simplicity of the technology that was repeated over and over again by those who had used Billy blankets or Billy cocoons already throughout their own previous hospital admissions for their infants. Something that did surprise me was the frequency of the statements that parents really already felt that in hospital settings, they were pretty much doing everything anyway. They were providing most of the care. And that it would not have been any different at home. So you can see that people felt like the current generation of new parents are fairly familiar with technology. This is fairly basic. Just plug in the device. And other people who said, we were basically doing it ourselves in the hospital anyways. So really not much of a change they felt from the situation at home. Lastly, the concept of having a better recovery at home for the birthing person was a really significant finding. And I know you are probably all thinking, like, yes, this is extremely obvious, and I could not agree more. But despite having how evident I think this seems to any of us who are involved in perinatal care, our system does continue to uphold treatment pathways that really disregard what would be what I consider to be an obvious finding. And I just wanted to highlight a few of these quotations. So someone mentioned that they were exhausted and hurting from the delivery. The daily treks to the hospital and walking through the hospital were very difficult on me. I have a few other quotations highlighted here. This individual talked about how she had to go back with her daughter due to jaundice 3 days postpartum. So I was in a room with only a chair to sleep in. 3 days postpartum with stitches and no support. Totally unacceptable care for mothers to be put in this situation and not what's best for baby. I have another couple quotations here echoing the same thing. It is very uncomfortable to heal as a newly postpartum mom while sleeping in a hospital chair and getting no sleep for 48 hours straight. Someone else who noted they were left entirely on their own to manage pumping, nursing, and phototherapy, and that would have been easier to do at home and actually be able to eat and sleep at the same time instead of being starved and sleep deprived. And so I really think these quotations underscore that our current practices are not family-centered, and they're certainly not centered around the well-being of the complete dyad. For the parents who responded that they would not have considered home phototherapy, our analysis generally uncovered three major themes that involved concerns about TSB monitoring, compliance, and an overwhelm or lack of support. The concerns around the need to return to the hospital for TSB testing anyway implied that any convenience that someone might save from home phototherapy would be lost if they had to do daily trips into the hospital for monitoring. Compliance was primarily noted as theoretical concern in that some respondents said things like, people aren't the best at following directions. I can't see parents following, this at home. It wasn't so much based on their own experience of being unable to be compliant in the hospital and therefore not at home, but just sort of perceptions about that. And the last category was overwhelm and lack of support. Respondents who said they would not consider home phototherapy really described feeling extremely anxious about their infants, with several comments about first-time parents being too new or too anxious to cope with home photo. There were also, parents who spoke to the general lack of support that they experienced in general with their newborns, and that adding home phototherapy would really have just sort of pushed them over the edge. And I'm just going to wrap up here with our last slide, just to describe that there are ways that you can take the responses, both from those who would consider home photo and those who wouldn't, and integrate them into thoughts on program delivery. So I think the barriers as well as the enablers are both really important when designing a home phototherapy program. We hadn't actually indicated that TSBs would have to be done in home or in hospital. So when those parents mentioned that this would be a barrier, we know, of course, that traveling in and out of the home immediately postpartum is very difficult for families. But most home photo programs in the literature that have been studied in RCTs do include TSBs being done at home by either a midwife or a nurse. And so this just means that our findings really support that model of care delivery. And in terms of the overwhelm and lack of support, I think this might be addressed when designing inclusion or selection criteria for the program. If someone just described a lack of space or concern about children breaking equipment, then perhaps these individuals are not the right or most suitable candidates for HPT. And I would also say the same thing about the parents who identified having significant mental health conditions and in particular anxiety, which came up the most in our responses. If somebody really, if this negatively impacts their perception of care at home, then perhaps this individual would not actually be the most suitable candidate for HPT. And so I think it's possible to really lean into the concept of shared decision making or informed choice with families if you're offering HPT, and not that it has to be sort of an all or nothing program. All right, I'm going to wrap up there because it's my time to move to questions, but I just wanted to say thank you, and I'm happy to take any questions.
Wonderful. Thank you so much, Lauren. I see a few questions that have come in. If anybody else has any other questions, please put them in the Q&A, but I'll just read out a couple that are here that we have already. One person's just looking at if they do have a parent or patient, excuse me, who's required phototherapy, where can they go to be included in this study to help get some more adequate power available for you?
Well, I really appreciate the offer to pass the survey around. I'll actually post the survey link in the chat, but it is also available on our social media page, which is London Midwifery. So yeah, I will share that in the chat. I really appreciate people's buy-in.
Perfect. And then otherwise, was it just an online recruitment there for your survey?
Yes, that's correct. The RAB actually had preferred us doing it online and through social media and not in person or in the setting of the hospital because of some concerns around just sort of like the burden of parents who were in like a very challenging and difficult time immediately postpartum, that catching them with signs at the NICU or the postpartum care unit they didn't feel was fair or appropriate. So it's been all social media based.
And in the studies that you had reviewed and mentioned in your presentation here, how was the home phototherapy funded? For example, was the blanket purchased or rented by the families?
That's a great question. In the European and Australian studies, they were all hospital-based programs that provided the equipment through the hospital. Many of them were pilots and then have gone on to become permanent programs. And the several of the studies as well involved midwifery-led programs that were essentially identical to the model of care that we provide here in Ontario anyway. And so it involved, midwives being the one to do the education, even to have diagnosed the need for phototherapy. Sometimes they consulted with the pediatrician to just sort of make sure that they were, good to go. They would bring them the equipment, teach them how to use it, and then do daily in-home serum billies. And so having 24-hour access as well, it was largely through their on-call midwives. So very, very similar model to what we have in Ontario. There were a couple of variations where it involved public health nurses, as well as some studies had parents going back daily to have TSBs done at an outpatient clinic. So, but the vast majority were midwifery-led in-home support.
And just a follow up with that one, so then the equipment like blanket, like Billy blanket and other elements were then recycled and available for the next family?
That's correct. So these units, as we found out, because we have a couple here in London, are run just shy of $10,000. I want to say there's somewhere in the $8,500 to $9,000 range, at least for the GE Billy blanket. And they have covers that the babies use that are disposable and then otherwise get returned and picked up by the midwife, brought back to the hospital and cleaned, at least in the studies.
Wonderful. And I've just got one last quick one, hopefully. How many hospitals in Ontario are you aware of that are offering home phototherapy, if any?
Yeah, there are hospitals that are offering home phototherapy in Canada and a couple in Ontario. I think they are generally fairly small scale programs, and I only know of them predominantly in terms of having heard that they exist. So, not aware of any studies of currently active home photo programs in Ontario. But please, if anyone is involved in these and can correct me, feel free to share it in the chat. But I've heard that Collingwood and maybe even West Lincoln and Milton are perhaps all running some home photo programs. So I'd love to hear more about that.
Incredible. Thank you so much for your presentation, Lauren.
Thanks so much.
Great. Thanks so much, Lauren. Our next presentation I'm really excited about. It's going to showcase one of the research projects that we are doing. We're currently kind of in the process of finishing it at LHSC, and it was undertaken by our interdisciplinary, it's a collective group with obstetricians, family doctors, midwives, nurses, and anesthesia and pediatrics. And what it is, it's a midwifery-led rapid review committee where research meets clinical practice. So our presenters today are Diane Moronic and Rebecca Thompson, and I'll be sure to put their bios in the chat. So you can go ahead and share your slides.
Wonderful. Thank you so much. Hopefully that's showing up well for you. So my co-presenter, Diane, and I wanted to take this opportunity to, like Megan said, share our opportunity that we had getting involved in research, and in particular in this rapid review, and how this research method in particular can be applied at other centers. Our brief overview for today is just being able to share how the idea of a rapid review committee was sparked in our community, a little bit about what a rapid review is and how to get started, some takeaway lessons, and how you might be able to recreate something similar. The rapid review process really took off during COVID-19 when the pandemic had a lot of practice changes and information that was coming in. And this offered a way of synthesizing evidence quickly and getting answers to research questions for evidence-based practice as information evolved. This helped clinical practice to adapt quickly. In comparison to a systematic review, the process is the same, where you want to have a replicable, predefined search and screening method to minimize the risk of bias, while the inclusion and exclusion criteria, though, for rapid reviews is generally more focused, or the timeline of articles corrected is shorter. For instance, you may look back at 5 years instead of the usual 30 with doing a full systematic review. So the goal is ultimately to get a sense of the data for a specific question with narrow criteria, so it can be done as quickly and efficiently as possible with not a lot of burden for the researchers. On our unit, as an interdisciplinary team, we wanted to be able to take advantage of the ability to quickly answer questions and not create a significant burden for the clinicians that were involved, as we all know that clinicians are very busy. This slide is just meant to provide a visual to the process, so you get an idea that there's a broad collection of articles that are included and then get filtered down through the layers. For the rapid review process, there is that initial search, a title and abstract review, full text review that then goes to data extraction, analysis or data synthesis, and then interpretation and communication of your results.
So we were first introduced to the idea of a rapid review by our limited term chair research team, which included Beth Murray Davis and Ginny Brenton. They suggested doing it so that we could present evidence from scientific literature that could stimulate change in policy writing or decision making on our labor and delivery unit. We knew it would be important to choose a clinical practice that stimulated a common goal amongst all the providers. So we needed to find an issue that had mixed practices on the floor. We brought together OBs, midwives, and anesthesiologists, nurses, and family doctors, and found they all felt somewhat differently about separating mothers and newborns at birth, and specifically skin to skin in the OR. The next step was to ask our advisory team of clinicians what aspects of skin to skin in the OR they felt should be explored. Much of what came back was around implementation and varying levels of comfort and education with this. We felt that the process of engaging stakeholders from all departments was really positive because it fostered a lot of interprofessional discussion, and we had conversations with clinicians that we otherwise wouldn't have had. Our final research question was, what are the clinical outcomes for both infants and birthing parents within the first hour after a cesarean birth with immediate skin-to-skin contact? This question and keywords for a search were brought to our LHSC librarian, Brad Dishan, who ran the search on our behalf. We chose to use Covidence, a software program that was easy to use. It keeps articles organized when working through inclusion and exclusion criteria at the various levels of title and abstract review, full text review, and data extraction. Criteria can be set for how many people need to review an article and be in agreement for it to be passed through. Covidence is available to access for those who have adjunct clinical status through McMaster's institutional license. Those who do not have adjunct status can create a free login and participate in the rapid review process, but at least one person involved in the review must have access through a paid membership or affiliation.
This is a screenshot of what it looks like when you log into Covidence. So we wanted to highlight this as an example of how streamlined and easy to use this program is, given that it's a very simple layout. This is a sample from our practice review session. So each area could be expanded. You would see your articles contained at each level. And as they move through, it shows you how many are needed to screen as well as excluded to be able to track along. In our experience, we are currently in the full text review stage. As someone who's not previously been involved in a research study, it has been a great learning experience to see that it has been a very accessible way to get involved in research and not intimidating at all. Our team is made up of 2 senior researchers, Dr. Beth Marie Davis, Dr. Jenny Brunton, both a midwife and a researcher at the Ontario Tech University, as well as our research lead, the leads of the project, and then as participants, 4 other midwives and a midwifery student. We then also have 2 research coordinators who are supporting the project. This has been a great way to work asynchronously, where everyone doesn't have to be in the same room at the same time, or being able to move through stages together. When more people are involved, we did find that the review certainly does go a lot faster, depending on how many articles get pulled for you. It has taken us a little bit of time to get everyone onboarded, but the leaders of the rapid review have created some videos that have helped streamline this process and then also aid for future reviews, because we've had some significant involvement and interest from other departments of wanting to take on some future topics. It is important to have someone that is assigned as the lead who can create a timeline and keep the project on track. They can assign articles to keep the project manageable for each person. For instance, in title and abstract screening, we decided on a number of articles that each person would review. And in the full text review, the lead has been assigning us specific article titles, 10 at a time. Communication with the team is also very integral. It is important to be checking in with each other to say when everybody is ready to move on to each step. We have created a WhatsApp group for checking in and also posing questions to the group so that we can gain knowledge together. Then we decided it's important to have someone come in from behind and re-review any included or excluded articles at each stage to ensure that everybody is going through the same criteria and applying it in the same way. Certainly as someone who is learning about participating in this rapid review process, this has been really helpful because feedback can then be provided on the quality of the screening that's being done. Be aware that although the number of articles gets fewer through the inclusion-exclusion criteria at each step does take more time as you're delving into everything in more detail. So in order to not get stuck too long on one article, it is safer to continue to include an article that might be seen as a maybe, and then as you move on to a more detailed step, it becomes clear as to whether or not it should be included or excluded.
So although our study is not yet completed, we wanted to offer some options of how you can apply the findings if you were to do a rapid review. So one idea is to publish as an interdisciplinary team, create a QI project to make those changes happen on your floor. You could present at rounds and discuss on why clinical practice may differ from evidence-based practice.
And then overall, we wanted to be able to share and make this something that can be replicated in different centers. So we are very happy to be able to chat with anyone else who might want to do something similar, to help answer questions, and to help learn how to get some of that clinician stakeholder engagement. You may want to find a topic that can bring your community together, or perhaps start a program but aren't sure of what the current evidence says on that topic. A review is usually the foundation of a change management initiative. So it's an important skill to have because many midwives or clinicians aren't always sure how to jump in and make a change or navigate all the evidence that exists. We want to create a framework that a midwifery department or organization can replicate, and then take forward, knowing that as a clinician, it is incredibly important to be able to filter through research, even if you aren't capable of conducting a full research study on your own. This skill set for being able to do a rapid review has been shown to be something that's really important for reading and appraising the evidence, organizing that evidence, and then being able to come up with a solid understanding of what exists in the literature. And then I've just included a reference there for one of the for the sample that we had. And thank you very much.
Wonderful. Thanks to both of you who presented that. Just to add a little bit about the training piece, we as we were going through this project, we were creating a framework for how to do something like this. So the project, it's taken longer than we were expecting, as is always typically the case in research. But it's been really interesting seeing the cultural response on the floor to this project. There's been a lot of interest. I think it's a really positive move towards building an interprofessional culture where it's kind of normal to ask questions and to explore other evidence-based options. So there's been some interesting side conversations that have come out of this work, and we are in the process of fishing through what is the next review going to be. And that's what's been really interesting, is now there is some requests to have medical students, midwifery students. We do have a midwifery student on this one. So it's been really interesting. We're also looking for grants to evaluate this process, to see, what the people who are participating in, how they felt about it. So we do have some time for questions. So I do have a question here. So the question is, I might have missed this, but if you can answer, were there tasks that you asked your hospital librarian to help you with specifically? So do one of you just want to reiterate the process a little bit, or I can do that if you want.
Yeah, so with that, our hospital librarian, we provided the keyword search criteria to be able to give them what we were looking for. And then from there, they led the search to be able to go through multiple different layers and find the initial included articles that we had. And I believe we had about 490 articles that we came up with our initial review.
Wonderful. And there's another question. What was your experience like going through it, having not done research in the recent past?
I know Rebecca mentioned it in her slide about lessons learned, and in my bio, you may have heard that I haven't done research since my undergrad. Obviously we all did Carl. We all love Carl. But yeah, it was a bit intimidating to sign up for a research project, but Meg had told me this was going to be something pretty straightforward, and I'm really glad that it was. I would encourage anyone to jump into something like this because it was super straightforward. Covidence really makes it quite easy.
Yeah.
And I would just add as well, based on the experience that Diana and I have had, I think has really made it easy for other members of the department to get excited about it and see, okay, they've filtered through those layers, getting the initial onboarding, troubleshooting a little bit of what we needed to help ensure that somebody being onboarded is aware of, has then made it easier for even the next people to be brought on. So some of the things that we have been able to communicate together is making sure that we are aware of how to find the criteria of what we should be included, as well as talking through different types of articles that we might come across, and learning a bit more in depth as to why or why not it might apply. So some of that has been through Diane and I going through the initial stages, and then being able to ask questions back to the research support that we had. And then now we've been able to create more documentation for the future people that are being onboarded.
Wonderful. And then the other piece is if you're, let's say you're primarily set out of a hospital instead of an academic center, there probably is ways that you could leverage some support, whether it's contacting maybe one of us or an affiliated center near you, to see what your resources are around your librarian, because the librarian really is key to helping you make sure that you've kind of gone about this the right way. And then that way you want to try to set that up from the beginning so that you're not going backwards when you've already started. So wonderful. So if there are no other questions, feel free to reach out to any one of us if you want to chat about this further. I know there is a list now of what we're going to do for the next reviews. And really it's coming down to almost like it's a vehicle to explore a quality improvement initiative. So for example, like implementing a water birth policy or something to do with the management of something that we think maybe needs to be revisited. I know anesthesia has reached out and asked if we could help do a project with them on something anesthesia related, which I think is really interesting because there are some mixed opinions about what they're doing within their own department related to epidurals. So it's always, I think that's always fascinating when we start to come together and share perspectives about what we could be doing and then using the evidence to guide us on that journey. Wonderful. Thank you both so much. I'm just going to go ahead and introduce our next speaker, just to give you a second, Rebecca. So our next speaker it's my pleasure to introduce Vanessa Hebert. She is a PhD candidate at McMaster University. I will put her bio in the chat. So Vanessa is going to share with us her research, which is titled Characteristics Associated with Planned Home Birth in Ontario, Canada, Results from a Population-Based Cohort Study. I'm just going to go ahead and spotlight you, Vanessa. So I'm going to make you a co-host so you can go ahead and share your slides.
Thanks, Megan.
No problem. I'm so happy to see you. I'm excited to hear about this.
Nice to see you too. All right, can you see my slides?
Yes.
Perfect. So hi, as Megan said, my name is Vanessa. I'm a registered midwife, PhD candidate in health research methods at McMaster University. I wanted just to begin by acknowledging that I'm speaking to you from Timiskaming Shores in Ontario, which is located on the unceded traditional and ancestral territories of the Beaver House, Matachewan, Temagami, and Timiskaming First Nations. And yes, I'm excited today to tell you about a study I was involved with on characteristics associated with planned home birth in Ontario. So the debate over home birth safety has been long-standing and divisive. And while a large randomized controlled trial could potentially help to settle it, birthing individuals don't want to randomly be assigned to a birth setting, making that approach impractical. So we need to explore home birth safety through observational studies. And as these article titles highlight, some previous observational studies have had methodological flaws that have sparked controversy and intensified the debate on home birth safety, highlighting the importance of ensuring that the research is rigorous and well-designed. So one major challenge in this research is confounders. So these are variables that affect both planned place of birth and safety outcomes. And without properly identifying and adjusting for these, it's really difficult to determine the true impact of birthplace on safety. And while there is plenty of research on the factors that are related to perinatal safety outcomes, less is known about the factors that influence planned place of birth, particularly in Ontario. And so our study aimed to identify the sociodemographic and clinical characteristics associated with planned home birth versus planned hospital birth. We conducted a retrospective cohort study using data from 2012 to 2018. We included Ontario residents who were under midwifery care at the onset of a spontaneous labor with a live cephalic singleton baby at term gestation, with no indication for mandatory transfer of care based on previous college guidance. And we gathered our data from several provincial administrative data sets, including the Born Information System. So potential determinants of place of birth included these demographic characteristics, environmental factors, health behaviors, antenatal factors, as well as variables related to previous obstetric history. And the outcome was planned place of birth at the start of labor, regardless of where the birth actually happened. So for example, if an emergency unplanned birth occurred at home, it was still classified as a planned hospital birth. And this variable was categorized as home or hospital, which means that we excluded any records where planned place of birth didn't fall into one of these two categories.
Vanessa, I'm so sorry to interrupt. Your slides, I think they're lagging, so that we can't really read them. I have your slides. Do you mind if I share them while you carry on?
Oh, that's too. So what slide are you seeing now?
It's the methods outcomes, but they're like they're like fuzzy. So that's better.
Oh, no.
I don't know if it was like kind of like a puzzle piece that was all mixed up, but it's up to you. I think it's just the internet. I'm happy to go to that slide if you want, or you can carry on if that's.
Okay, Meg, I'll carry on, but let me know if it continues and then we'll switch over.
Yeah, beautiful. I just don't want to miss your slides.
Yeah.
Let me know. We are ahead of time, so we do have a bit of time.
Okay. I'll just let me know if it continues. There's one slide that's a bit complicated, so I'm a bit worried about it, but yeah. Okay, so in terms of analysis, we used a multivariable regression analysis to assess how each factor independently affects choice between home and hospital birth. And for each factor, we calculated something called the population attributable fraction, which is just basically the proportion of planned home births attributable to that factor. And we conducted separate analyses for nulliparous and parous individuals. Still good, Meg?
There's a problem.
Still a problem? Do you want me to stop sharing? Meg, you're muted.
Meg, you're muted. Yeah. Why don't you stop sharing, Vanessa, and Meg will pull yours up, and then and then you can carry on.
Sorry about that, everyone.
No, it's not your fault. It's just better if you have what you brought. Okay, slideshow.
Yes.
Okay, just let me know when you want me to switch.
Okay. So are you on the results page, on the results section? Yeah.
We are there.
Okay. So you're seeing that nice sort of flow chart. So after exclusions, we included just over 85,000 low-risk individuals, and among them, 20% of nulliparous individuals and 29% of multiparous individuals planned a home birth. Okay, next slide. Okay, so this is that tricky slide, Meg, but I'll just tell you how to navigate it. So right now you're looking at a forest plot that shows our results. The vertical line indicates no effect or no difference between groups, and dots to the right of the line show the factors associated with planned home birth, while those to the left indicate factors linked to planned hospital birth. And for nulliparous individuals, some of the strongest associations we found include, okay, so right at the top of your screen, being 35 years or older, which was linked to a 39% increased chance of planning a home birth, while those under 20 were about 1/3 less likely to plan one. The variable below that is race. Now, race data in born comes from prenatal genetic screening requisitions, and it's only available for those who participate in screening. Missing race data indicates opting out of genetic screening. And those who opted out were about 33% more likely than white individuals with genetic screening to plan a home birth. Okay, Meg. So if you can just, so to scroll up, you have to hit the space bar, and to stop, you have to hit the number 3. So if you can hit the space bar and scroll up just a little bit to just a little bit.
Okay, let's try this again. So which variable do you want?
Okay, stop right there. Perfect. Okay, so sort of towards the top, you see health insurance coverage. So not having OHIP was associated with a 36% higher chance of planning a home birth. And then the variable right below that, missing geographic location information, was linked to nearly 3 times the chance of planning a home birth. And since this variable was only available for those with OHIP, this association may also be related to lacking OHIP coverage. Okay, Meg, if you want to just scroll just all the way to the bottom. So just just keep going until it stops. Right there, that's perfect. So individuals with diet control gestational diabetes towards the bottom of that screen were half as likely to plan a home birth, while those missing this data, likely due to opting out of screening, were almost twice as likely to plan one. All right, if you want to just skip to the next slide. Oh, and I'm going to skip to on my end here, sorry. Okay, so these are the results for multips. Well, we found similar results for parous individuals. And in addition, for multips, being a repeat midwifery client was associated with a 54% higher chance of planning a home birth, while having had a prior cesarean birth was linked to a 59% lower chance. All right, next slide, please. So the highest population attributable fractions were for parous individuals who were previous midwifery clients, and you could just animate that. And for nulliparous and parous individuals who opted out of prenatal screening, and you could animate that as well. And then we can skip to the next slide. So key strengths of this study include, so the first one is that this is the largest study of its kind. Thank you. And then the second one is that we identified potential determinants of birthplace through a thorough literature review. And the third strength is that we had access to rich data from multiple data sets, allowing us to explore most of these determinants. And then in terms of limitations, the first one is that we lacked data on previous birth experiences, like previous home birth or previous complications. The second is that that variables based on postal code were only available for those with a valid OHIP, potentially introducing some selection bias, but we addressed this by including a missing category in our analyses. And then the third limitation is that our data extended only to 2018, missing any changes in the home birth landscape post-COVID. Next slide, please. So you can animate the first one there, Meg. So there are 2 important themes that emerge from the study. The first is that many factors associated with planned home birth, like missing dating ultrasound and opting out of screening, indicate a preference for avoiding antenatal testing. And this aligns with common reasons identified in the literature for choosing home birth, like valuing autonomy and avoiding medical intervention. And then the second theme is that while many individuals choose home birth based on an informed philosophical decision, our study found that lack of OHIP coverage was also linked to planning home birth. And since uninsured individuals often experience greater material deprivation, this suggests that financial necessity may play a role for some, which shouldn't be overlooked. Next slide, please. I'm almost done. This is our last slide in terms of key takeaways from the study. The first, of course, is that there are key differences between those planning home birth and those planning hospital births. The second is that previous midwifery care and opting out of prenatal genetic screening were important factors in deciding on a home birth. The third is that because we now have better information on potential confounders, these findings will help to strengthen the design of future home birth safety research. And in fact, this is the next phase of our project to study home birth safety, and we'll be using data from this study to help inform the design of that project. And finally, these findings can be used by policymakers, advocacy organizations looking to develop targeted initiatives aimed at supporting access to choice of birthplace options. I would like to thank my co-authors on this project, ICES for supporting this study, and the AOM for providing funding for this project. And I apologize for the technical difficulties. And happy to answer any questions.
I was just going to say, way to go, Vanessa, because we couldn't see anything before. So way to just like wing it and let me muscle through it. So I appreciate that. I actually feel like we got more out of your talk because we switched the slide deck. I could see what you were talking about. So thank you for rolling with it and not quitting on me.
Oh, I'm so sorry that happened.
No, it's okay.
Thank you so much, Vanessa, for your presentation and for being able to be willing to conduct research on home birth in Ontario. For the present moment, we're going to hold questions until all three of our presenters from our research showcase have finished. These researchers are showcasing Ontario research with our three amazing guest speakers, and each presentation, like Vanessa's, is going to be about 10 minutes each, and we'll have an ability to post questions for all of those at the end of these. So please feel free to go ahead and post anything in advance in the Q&A, and I can continue to read those out once the remaining two presenters have finished. It is now my pleasure to introduce Sandra Matilva, a PhD, who will be presenting on leveraging artificial intelligence to advance midwifery practice, a systematic review of innovations and challenges. Welcome, Dr. Matilva. You can now share your presentation by pressing the Zoom share screen at the bottom of your screen.
Thank you for having me and for the opportunity to present my systematic review about artificial intelligence in midwifery. So I am in Ottawa, so I would like to begin by acknowledging that the land we gather is the traditional unceded territory of the Algonquin and Anishinaabe people. These people have lived in this land since time immemorial, and I am grateful to have the opportunity to present in this territory. So this review highlights the benefits, limitations, and risk of AI in midwifery, and it aims to offer recommendations for education, research, governance, clinical practice, and policy development. So recognizing AI as a powerful tool underscores the need for the midwifery professionals to adapt. So because AI is here to stay, and I performed this review since reviewing titles from 2000 to the end of last year, and the amount of growing in terms of titles related to AI is incredible. So in fact, the research shows that over 33% of the research, there is an annual increase in titles related to AI. So AI fits in midwifery, so anything that is related to AI fits in midwifery, because the integration of AI is not just a technical or engineering phenomenon. It is a social one where relationship, ethics, and professional values are going to be impacted. So here is a high-level definition of AI, of the AI universe. AI is just an umbrella term, and the term that the definition that I included in the slide is from the Organization for Economic and Cooperation Development. And AI has 7 different case users. All of them are applicable for midwifery, and I don't have the time to go through them. But it's just that there is a terminology that has several disciplines involved. So in this slide, I am showing the methodology that I adopted for this review. The diagram that you see is from the preferred reporting items for systematic review and meta-analysis. Is the Prisma flow diagram that shows my process. I started with over 1,700 titles using, of course, Covidence, and I finished with 102. So in the first, so there is hardly any midwifery main investigator or authors involved in AI. So I started, that's why I needed to expand my population. I started with midwifery, but then I needed to expand to nursing, OBGYNs, or other perinatal providers that produce conclusions that could be applicable to midwifery. So in terms of theory applications, there are several theories there that are associated with for the innovation and also AI. So the one that I applied is the technology acceptance model theory. That it was a theory that was developed in late 80s, the beginning of the 90s. So moreover, this protocol was approved by Prospero. So for every one of you who has done a systematic review, know that Prospero is quite rigorous, and so I feel very proud to have this protocol approved. So in terms of the results, so as I mentioned, there were a few titles that involve midwives as main investigators related with AI projects. Most of them are in Europe, some of them are in the USA, and there are other groups in Africa. This study was mainly applied to clinical practice, directed to client care. And what the literature highlights the most is that the risks and limitations is the poor quality data sets that were used to evaluate those systems, has the risk to introduce bias. There is the need for clinical interpretation results. So that means that midwives will need to have some kind of technical expertise related to AI. And the main issue was inadequate expertise and involvement among midwives. So AI is showing that it's already enhancing decision making. It helps to improve quality care, and of course help with system performance. In terms of midwifery, might help to support clinical decision making. Virtual care has highly great evaluation in the literature, as enhances client interactions through visualization and also auralization of environment, especially for clients and clinicians who have disability. chatbots. There was a chatbot that was evaluating in the literature that was created for midwives that is called Molly, and it is performing in certain areas of the world that connect midwives with clients with midwives, and it is reducing administration burden and also cost, and of course generative AI and robotic technology. The amount of papers related with robot and technology that are coming every day is incredible. The last one that I encountered was an exoskeleton robot that is used by clinicians that are performing no very ergonomic task, and I think that could help midwives too. And like surgeons or nurses or support workers, and this particular robot decreased the amount of ausentism and lesions in the or musculoskeletal discomfort. But for all of these, AI require ethical considerations as new challenges emerge in its integration in healthcare. So the literature shows that AI has a transformative power, but it requires involvement and understanding of its implications. So it is important to understand that AI is only a substitute of, is not a substitute of clinical care. It's a tool that can help with assist with diagnostic accuracy and other applications. It cannot replace midwifery, and it will not be able to replace nursing to the full scope. However, AI is showing that it could be, I don't want to use replace, but it could be performed in, especially in some disciplines in medicine, like for example, diagnostic, anything that has to do with imaging diagnostic. And it will, of course, enable, it was a study published in the Journal of Medical Internet and Research that physicians that use ambience AI tools for clinical notes shows that they could, 100% of them could focus in their patients, comparing with 25 and 50% of physicians that were not using the tool. So that requires obviously urgent preparedness from the profession. So it is important to develop guidelines and governance framework for the integration. And of course, there is a huge opportunity for future research in the area of AI in midwifery, because as I mentioned, there is not many investigators, and also there is funding available too. So I wrote this conclusion that says the evidence from this systematic review highlights the urgent need for the midwifery profession to organize for the integration of AI, ensuring that it enhances rather than disrupt the professional values and the care provided to clients, as right now all the AI systems and products are being developed by technologies with other professionals and patients in mind. So it is important that midwives start to be involved in this development of this technology. So these are the references for this review, and I am open for questions. Thank you for the opportunity.
Thank you so much. I imagine that we are going to see a lot more of this technology as it continues to advance. And if you don't mind sticking around for the next presentation, and we'll take questions right after that, if that's okay. So it is now my pleasure to introduce Jessica Jones, registered midwife and adjunct assistant clinical professor in the Department of Family Medicine at McMaster University, who will be sharing her research presentation titled How Midwifery Clients in Ontario Access to Information to Support Infant Feeding Decisions. Thank you for starting to share your slides. You may now go ahead.
Thanks. I'm just going to have to reshare just so I can access my video button. Okay. Good afternoon, and thank you to the conference committee for inviting me to present today. I'm excited to be here to discuss this research, which was conducted in partial fulfillment of my Master of Public Health degree through McMaster University. So before getting into this presentation, I would like to acknowledge my co-researchers who provided the necessary guidance as part of my thesis committee, and Dr. Alvarez, Dr. Anderson, and Dr. Murray Davis, all from McMaster, and the support and encouragement of the Hamilton area content experts, the Ontario midwifery community at large, in contributing to the development of this work. This research was and continues to be supported by a mentored midwifery research grant through the AOM. I would also like to acknowledge the fluidity of language and the importance of building inclusion in both academic work and clinical practice. In the context of infant feeding, there is growing use of the term chest feeding as an alternative to or in conjunction with the term breastfeeding in order to reflect how individuals nurture children from their bodies. For the purposes of reflecting current literature and consumer information sources, the term breastfeeding was featured more prominently throughout this research and will be seen throughout the presentation today. So why midwifery? So why this study and why midwifery clients? So the initiation and duration of exclusive chest breastfeeding are important health determinants for both lactating individuals and their infants. Since the early 1990s, the protection, promotion, and support of exclusive breastfeeding as a key public health issue has been reflected in various aspects of public health policy and program development. And midwifery clients in Ontario were often credited with higher rates of exclusive chest breastfeeding than the general population. We can see from this chart that across the province, there are high breastfeeding initiation rates that then dramatically drop by 2 months of age, while midwifery-specific rates at the 6 weeks of age or discharge from care, reasonably comparable time point with the general population, are significantly higher. Given that the dissemination of health information for consumer use is a key factor of success for any public health policy or program, I approached this study feeling that there were lessons to be learned from Ontario midwifery clients and about how their information access patterns. So the overall goal of this research was to describe how midwifery clients in Ontario access information to support their infant feeding decisions. Specifically, I was interested in when and where this information is being accessed, factors used in determining the importance or influence of these sources, and potential areas of programming and service development. So the study was conducted as a descriptive cross-sectional online e-survey. All eligible midwifery clinics in Ontario, including the provincial associations, 95 groups in total at the time, were contacted for support with study recruitment. Groups were provided with specific study recruitment tools for local and online use, and a publicly available, accessible study Facebook group was also maintained throughout. All midwifery clients in Ontario aged 16 years and older, either currently receiving or recently discharged from care, were eligible. We were looking for 200 completed surveys in order to achieve our sample size for this descriptive study. The survey was available for completion over a 4-month period and accessed through a secure web application. Data analysis was completed using descriptive statistics for closed-ended questions and content analysis for open-ended questions. And ethics approval was obtained for this study. Okay, so the Midwifery Infant Feeding Information Survey Questionnaire was the survey instrument developed specifically for this study. We used published surveys and practice guidelines from the literature, in addition to unpublished local surveys and personal clinical experience to support the development of the questions. The questionnaire was evaluated for both face and content validity using volunteer midwifery clients from the Hamilton community and local midwifery and public health experts. A grade 6 to 8 reading level suitable for health questionnaires was developed using an online tool and validated with 2 very fortunate school-aged children. And the final beta testing was conducted in order to confirm general usability and technical functioning of the e-survey before going live. So the final questionnaire contained 51 items with a mix of open and closed-ended questions. We had 308 Ontario midwifery clients recruited to participate in the study. A total of 235 completed questionnaires were used in the final analysis, with a mix of both prenatal and postpartum respondents. So who participated in this study? This slide highlights some of the baseline characteristics of the survey respondents. We see that they ranged in age from 19 to 40 plus, with over half of them being between 30 and 34 years of age. The majority of respondents identified as belonging to an urban community, having a college or university degree. The relatively balanced number of nulliparous and multiparous respondents. Vast majority of respondents were either experiencing or experienced a singleton pregnancy. Prenatal respondents in their second trimester or late third trimester were the most represented, and postpartum respondents, vast majority delivered a term newborn, and more than half were 7 or plus weeks postpartum at the time of survey completion. So in the survey, respondents were presented with a list of possible infant feeding information sources and had asked to identify if they had either accessed the resource during the prenatal or postpartum period as applicable, and if they had, how useful they found it to be. So this chart summarizes the top 3 most accessed and most useful information sources identified from both groups. And we can see that midwives were reported as the most accessed and most useful source from both prenatal and postpartum respondents. And I'm sure this result is not a surprise to anyone attending here today. The access and usefulness of other information sources varied. However, common to both groups were in-person lactation consultants, family and friends, and online digital media. So we know that midwives were the most accessed, rated as the most useful information source for clients. Great. But I wanted to know more about that information exchange. So I looked specifically at what infant feeding information midwives were discussing with their clients in the prenatal period in order to support this informed decision-making process. This chart lists the response options provided in the survey. Bolded items are specific infant feeding discussion topics identified from the literature. Respondents indicated that discussions around the benefits of breastfeeding and postpartum supports for breastfeeding were the most discussed topics, while the risks of formula feeding was the least discussed topic. Interesting, 17% of respondents, both prenatal and postpartum, indicated that there was no discussion of infant feeding with their midwife. So this next chart summarizes the results of the content analysis exploring usefulness and preferences of information sources. We see that respondents find useful resources to be highly accessible, foster a degree of confidence and trustworthiness, and offer personalized support and reassurance. Preferences for accessing information include in-person interactions with healthcare providers, online digital media, and organized formal classes. In terms of preparation for infant feeding, respondents indicated a preference for more anticipatory guidance around the infant feeding experience. So I want to take a moment just to review some of the data collected regarding infant feeding methods. Amongst the postpartum respondents, when asked about their current feeding method, 74.8% indicated that they were only breastfeeding, with the remaining respondents using a breast milk substitute to some degree. This rate of perceived exclusive chest or breastfeeding is reflective of the corresponding reported midwifery specific rate of 77%. However, when this same group was asked if their baby had ever had formula, only 54.1% of respondents would be considered to be exclusively chest or breastfeeding by the definitions set by the Breastfeeding Committee of Canada. And this rate is more reflective of the corresponding reported rate for the general population of Ontario, which uses that same reporting criteria. But perhaps more interesting is that only breastfeeding or not, the majority of respondents, 71.7%, indicated that their current feeding method was consistent with what they had planned. So what does all of this mean? The results of this study found that Ontario midwifery clients actively access information to support their infant feeding decisions throughout the continuum of care. and that the midwife-client relationship appears to be a central part of supporting that access. Other important information sources included family and friends, which were highly accessed, and the online digital environment, which was rated as highly useful by both prenatal and postpartum respondents. This finding is likely reflective of what is referred to as the millennial effect, whereby the use of online digital media is often used to fill information gaps and seek social supports, or largely viewed as a generational approach for today's childbearing families. And while midwives are discussing infant feeding with their clients prenatally, a number of topic areas were either infrequently discussed or missing altogether, indicating that potential barriers may exist for midwives in delivering comprehensive information and supporting informed decision-making. While it was beyond the scope of this study to investigate that further, from the literature, it may be the result of a lack of knowledge, resources, or counseling skills. The results of this study also suggest that rates of exclusive chest or breastfeeding within the Ontario midwifery population may not be as high as previously thought, and may in fact be on par with provincial rates. I say this, of course, with a full understanding that the use of the term exclusive breastfeeding can be problematic, and the lack of standardized infant feeding surveillance data on Ontario limits our ability to make such generalized comparisons. However, I would argue that from a clinical program and service development perspective, meeting the planned feeding method versus a strict adherence to an exclusive breastfeeding criteria may be a more important indicator in developing strategies to support infant feeding. So there were two particular strengths in this study. First was the development of the descriptive cross-sectional survey instrument. With further evaluation, there is potential for this to be used in future studies. And second was the robust recruitment approach that enabled us to achieve both the planned sample size and a breadth of client experience and engagement with this study. However, as with all research studies, there are limitations. Specifically, e-surveys, while absolutely cost-effective method to reach a large study population, they can be subject to considerable bias. While care was taken to ensure that recruitment materials were welcoming to all clients, regardless of their planned or current feeding method, there potentially exists a group of clients with more moderate experiences that did not complete this. And last but not least is the COVID pandemic. So this study was conducted during the fall of 2020, winter 2021, when many individuals in the province were living with the reality of restrictive lockdowns, a shift in the delivery of healthcare services, pregnancy-related care included. So it's not unreasonable to think that individuals may have modified their information access patterns in order to address these challenges, and that may be reflected in these results. But while we don't have a pre-COVID baseline to compare to, it may not be particularly relevant if we consider the possibility that this actually reflects improved efficiencies in the delivery of care, perhaps the new normal, offering us an opportunity to use these findings to shape a new infant feeding information landscape. So where do we go from here? Of course, more research is always needed. But specifically, the results of this study highlight that there is a need to build capacity around improving communication between midwives and clients and leveraging an online digital information environment. We need to identify barriers midwives may face in facilitating discussions on infant feeding to support informed decision-making and develop approaches to address those. And while there is a strong preference from respondents towards online digital media access, we need to better understand the effect of health literacy in an online information environment specific to infant feeding information. And this will then inform the development of, evidence-based, dare I say, midwifery specific online digital applications in order to support clients to meet their feeding goals. So this concludes my presentation, and I would welcome any feedback or questions at this time.
Wonderful. Thank you so much, Jessica. If you don't mind stopping sharing, but leaving your camera on, I would also like to invite Dr. Matilda and Vanessa to turn their cameras back on for our Q&A. For these presenters, please feel free to post questions again in the Q&A, and we'll be able to go through a few of those questions. So just looking at our Q&A, the first one that I have here is directed for Sandra. Do you see any use of AI or LLM in transcription for maintaining medical records?
Yes, LLM means large language model. It's a form of machine learning, and in fact, it's been already used. It was a big announcement a few weeks ago that Oracle is incorporated AI and machine learning into their EMR. And right now, physicians are using that, in which you can command your computer, or even you can have an application at your phone in which you can command by voice and gather specific information that you need from a patient, and is saving an incredible amount of time. Is highly accessible, and also is fine-tuned for medical terminology. So you can basically talk to the system and use the language, medical language, without writing anything. Is HIPAA compliant, and also which is for North America, and is also GDPR compliant, which is for Europe. So this is one of the companies that is doing that, and definitely, yes, there is lots of use, and it's already there. That is my answer.
Thank you. This question is for Vanessa. Was there anything in your research that you found surprising, or something that you think midwives need to know when it comes to supporting home birth with their clients?
Yeah, thanks. Great question. Yeah, the study, I mean, on the one hand, we confirmed previously reported associations. So things like older age, rural residents, being a repeat midwifery client, are linked with planned home birth. So we sort of knew that from previous literature, and things factors associated with a hospital birth included smoking, having had a previous preterm birth, previous cesarean delivery. So that wasn't new. In terms of surprising findings, there were some divergences, particularly with the studies conducted in the States. So we found no association between mental health concerns in pregnancy and planning a home birth. So previous research had shown that in the Netherlands. We also found that living further away from the hospital was associated with planned hospital birth for nullips, but that there was no association for multips in terms of distance from hospital. So that's different from the studies in the US. And then one more surprise was assisted reproductive technologies had been shown to be associated with hospital birth in the Netherlands, and we didn't find that association with the data that we looked at in Ontario. So yeah, some surprising findings.
Very fascinating. Thank you. Those will be interesting to explore further. This question is for Jessica. Did the findings indicate the frequency or timing prenatally on the topic of breastfeeding and midwifery care that was most effective for assisting with decision-making to breast or chest feed?
Great question. No, this was really sort of a preliminary descriptive study that was looking really more about information access patterns. So we didn't specifically ask, like, how many times did you discuss with your midwife? How many times would you have liked to discuss with your midwife? Like that, the timing piece, it was more just, hey, did you have these conversations with your midwife or not? And we didn't it wasn't like a longitudinal study where we would be able to kind of follow people to see, how many conversations they had, did it influence their decision? Because ultimately, this study wasn't about, did all of these interventions increase chest or breastfeeding rates. It was just, how do you access information? How do you prefer to access information? What does that look like? So we never looked at that particular variable. That piece that I presented around how people are feeding and what those rates are, exclusive or not, was really more just, it was a piece of the data that came out that was a little bit surprising, but when you start putting all the pieces together, it became a little bit like, hey, is it really about exclusivity or not, versus did they meet their goals and were their infant feeding goals informed, and the role that the midwife plays in that.
Amazing. We have time for just one more question. So if our presenters here don't mind, there are some additional questions in the chat if you had a minute to stick around to answer any other ones. But I'll just pose this last one here just because it had been higher up in the chat to Sandra. What impact could AI have on the relationship between midwives and their clients?
The evidence is showing that the application of AI as an assist or the assistant tools can help the midwife to focus more on the physical and emotional needs of the client. For example, all the robotics that is out there, the assistance robots, for example, that they are already functioning, can help maybe in labor you to focus in emotional support or clinical care to the client, instead being distracted with other tasks that usually, I don't know, when I was a midwife, sometimes I needed to leave the room to bring a warm blanket or ice. So if you have a robot assistant, your robot assistants can do that work. If you have an ambience assistant, can take the notes for you. So you can listen to the client without turning your head to typing or doing handwriting. It can also help with saving administration tasks in terms of money. The amount of money that goes into administration cost in Canada is incredible. It's around $26 billion. So imagine leveraging AI tools that are out there can help not only to save cost to your practice, but also for you to be focusing the emotional and physical needs of your client.
Oh, wonderful. Well, I thank you all for the research that you're working on and the stimulating discussions. And thank you for everyone who has been posing questions. I think this is absolutely fantastic to get this kind of engagement in the research that's being conducted here. So our last presentation for our Advancing Research Day for day 1 of 3 of the Ontario West Midwifery Conference is Megan Furnival and Dr. Beth Marie Davis. Dr. Beth Marie Davis is a registered midwife and educator in the undergraduate and graduate midwifery programs at McMaster. They will be showcasing our LHSC research on the topic Clients' Perspectives on Continuity of Care, Practical Approaches to Supporting Continuity. Thank you for sharing your slides, and you may now proceed.
Okay, thank you very much for having us. I just want to confirm that you're seeing my slides, or are you seeing my notes? You're seeing my slides. Okay, perfect. So yes, Meg and I are going to be tag teaming this. So we will try to keep it on topic and moving efficiently through our material. So thank you for the introduction and for the invitation. My name is Beth Marie Davis, and I am grateful to be able to live and work and play on the traditional lands of the Anishinaabe and Haudenosaunee nations. It's the lands that are protected by the Dish with One Spoon Wampum Agreement and adjacent to the Haldeman Treaty Territory. And on behalf of our study team today, myself and Meg and Christine Sandor, Momina Khan, and Julia Simeoni, we are happy to share some preliminary results from our study about continuity of care, understanding how it's defined and experienced by service users. And this was funded through MMRC Research Awards. So we're grateful for those funds to make this study happen. So I think this audience, a lot of this background stuff is going to be, things that you are well aware of, that you live and breathe every day. But just to make sure that we're all starting from the same place, I think it's good to define the concept of continuity of care. So it is a concept that is not unique to midwifery. It is seen in many other health and social care domains. And at its core is this idea of how one person experiences care over time. In the literature, there's often a distinction made between continuity of care, which is the care that's provided and the consistent philosophy or approach to care that underpins that, versus continuity of carer, which is the concept of having a known midwife present throughout the person's care. So when we talk about midwifery continuity of care models, we're talking about the idea of almost both of these things kind of intertwined, the idea of a same midwife or a small team of midwives providing that consistent approach throughout this childbearing cycle, including pregnancy, birth, and the early parenting period. There has been some research and literature on continuity of care and probing more deeply into these definitions. One of the key authors on this is Freeman, who started to define continuity even more in depth, and they defined 3 types of continuity. So management continuity, which is when there is that consistent approach to care, and maybe that's informed by care pathways or coordination of services. Then there's also informational continuity, which is how we transfer information about the person and how we share that kind of accumulated knowledge about their experience between different care providers. And then finally, there's relational continuity. And this is that kind of ongoing provider-client relationship that really is informed by that consistency of the same care team. They also, Freeman and the research group, talk about experienced continuity, that really we should be looking at how continuity is experienced by those in the service. So that was definitely part of what prompted us, and recognizing that this is really kind of a multi-dimensional concept. So again, this is going to be review for many of you, but I think it's really important to name that the concept of continuity of care is really such a core kind of piece of the model of Ontario midwifery, and that it's been reinforced and sewn into our model of practice in so many ways that we may be conscious of or not conscious of on a regular basis. So in particular, there's regulatory standards, there's our funding model, there's even the education model for student midwives, and all of those things reflect this emphasis on continuity. So many people will remember that the College of Midwives of Ontario actually used to have, as part of the regulatory standard, that there was a limit to the number of midwives that a client could meet, that they were restricted to 4 midwives through that course of care. And failure to meet that could actually prompt kind of further discussion with the regulatory body. Those care standards changed in 2018, but we still see that continuity is really a key part of the standards that's reflected in the leadership and collaboration domains, and that there are specific provisions around the midwife's responsibility to provide continuity of care by developing that ongoing relationship of trust with the client. We also see that continuity of care is reflected in the policy and philosophical documents of our profession. So there's lots of discussion about how midwives offer care throughout the childbearing cycle, and that there should be a known midwife available on call for clients 24 hours a day, 7 days a week. This is also further operationalized in our caseload funding model that underpins the model of care, at where each midwife is essentially paid a lump sum of money per client or per course of care. And then finally, from an education perspective, we have kind of perpetuated this model within the training for our students, who actually maintain and count their numbers of the number of clients that they achieve continuity, which we define as attending a minimum of 5 visits during the pre or postnatal period and attending the birth. So students right from the beginning are built into this kind of concept of case loading and continuity. So also by way of background, I'll just share the kind of a really brief snapshot of what is already known about the evidence around continuity of care. And there's lots out there. So if this is a topic that interests you, go and read more deeply. But when we look at midwives' perspectives on continuity, we see a lot of mixed feedback across the globe. So at a basic level, there's an understanding that the relationship-based model that midwives practice in is usually a factor that gives midwives joy and meaning in their work, which is fantastic and sounds really important. When we go specifically like country by country, we see a lot more variation. So in places like Australia, they've identified actually that they have lower rates of burnout for midwives who work in continuity models. In the Canadian model, we have growing evidence around, challenges about work-life balance and some literature on attrition. And so while midwives, appreciate the philosophical importance of continuity and they recognize that it might promote client satisfaction, there may also be challenges about the on-call demands of long work hours and the challenging on-call lifestyle. So one of the potential explanations for why there are these differences in different places across the globe, it really comes down to the ways in which midwives are able to work and structure their job. So in particular, when people can choose to work in an on-call continuity model rather than another, that may actually contribute to their job satisfaction and autonomy. Whereas in Ontario, we really only have one way of working and continuity is embedded into that, as I already mentioned. So I think when we're looking at this kind of global conversation and issues of sustainability and burnout within our profession, it's really important for us to keep teasing apart this intersection of continuity and how midwives perceive that as part of the picture. From the literature, there's also a good kind of growing number of studies related to the client perspective of continuity. So there is a Cochrane review that many people are familiar with, and it was actually recently updated in April 2024, looking at the impact of midwifery continuity of care models compared to other models of care. And the outcomes are great for clients. So there's an increased spontaneous vaginal birth rate. There are higher chances of having a positive birth experience overall and satisfaction. There's lower rates of cesarean section, lower rates of instrumental delivery, and lower rates of episiotomy. So when we start to think about continuity as an intervention, it is actually a really powerful tool to promote those positive outcomes among clients. There's still, I think, some gaps in what we know about the client experiences, and that led us to do our study, which Megan is going to tell you about.
Yeah, so to date, there's really been limited research in Canada that explores the client's perspective on continuity. So that's what really sparked our interest in seeing sort of the second half of this equation here. So the aim of our research was to understand the concept of continuity from the perspectives of clients only. Our research question was, how do midwifery clients and their families in Ontario define, experience, and perceive continuity of care? So we obtained ethics approval in April this year. And so I'll be able to share some of the results from our survey today. But let me tell you a bit more about our methods first. So we designed a mixed method study with two components. So there was a provincial survey, and then there's this batch of semi-structured interviews with midwifery clients. So for the survey portion that we're going to share about today, we created our own data collection tool, and it was based on existing literature and available tools. And we modified them for an Ontario context. So the questions included things like demographic information and Likert scales, and the survey responses were analyzed using SPSS software. The results they'll be reported in terms of descriptive statistics. So in terms of the study population, we plan to include clients who had a midwife for a singleton pregnancy in the last 5 years. And given the difficulty in recruiting this population and with the survey methods in general, we planned for a sample size of about 500. We regularly looked at our data to see where in the province we were getting responses from, and then we went about targeting recruitment efforts to fill in the gaps in these areas. So we really tried to get as broad of coverage as we could within the province. So the final number of the survey respondents, we actually got 515, and we recruited between May of this year to October of this year. And in terms of geographic location, we used postal code to determine that. And you can see the distribution here in the map of the survey participants, and you can see the midwifery practice groups are the gray stars that you can see here. So they represent the 95 MPGs in Ontario. And then the red pins indicate where we gained participant feedback from the surveys from. So some key points about the demographics of the survey. So the demographics are obviously very important here. So most of the participants that we were able to recruit were between the ages of 30 and 34 years old. 31% of them were having their first baby, while 37% were having a second baby, and about 15% were having a third baby or a subsequent baby. 40% of participants had midwives for the first pregnancy, while the remaining 60% had received midwifery care for 2 or more pregnancies. 80% of our sample identified as white, 12% identified as non-white, coming from East Asian, South Asian, Black, Latin American ethnicities, and 89% identified as straight, and almost all identified as women. So when we asked if they were satisfied with their care, we received a 96% agreement. 96% said that they agreed or strongly agreed with this statement. So Beth and I really paused at that to sort of just have a minute to say that this is a big number. So that's a really important number. So here's some information about the pregnancy and birth outcomes for the survey participants. So 84% had a spontaneous vaginal delivery, 6% had an assisted vaginal birth, and 15% reported a C-section. 27% reported an induction of labor, 39% reported getting an epidural, and then as well, 39% also reported a transfer of care to the obstetrical team. And 40% reported having anxiety and depression, and 70% reported still exclusively breastfeeding at 6 weeks. So I know these are a lot of numbers. This is a tendency with the survey sort of reporting, but 71% of the participants had a hospital birth, 22% had a home birth, and 4% had a birth center. And I believe 2% had sort of like none of those locations.
Yeah, or a midwifery. We did ask about midwifery-led units in hospitals. So there's only a couple around the province, but they were captured there. Okay, so what did we find out from the participants about continuity of carer? So first, we actually really wanted to know, did this happen for them? How many midwives did they meet? Was there a known midwife at their birth? And so when we were asking client or participants about the number of midwives that they met, 42% said that they met 3 midwives. That was the most highly ranked category for that question, followed by 4 midwives, which was the experience for about 25% of the participants. And then meeting 2 midwives was reported by about 16%. And it's important to note that 16% also met 5 or more midwives. We also asked participants if they did have a known midwife at their birth, and 92% of people said yes, which is, again, a moment to pause and just recognize that that's a pretty incredible number. The third question we asked related to the continuity of carer was around what the participants thought was the ideal number of midwives. So we know what they actually had, but we also wanted to know what they wished they had had. And 85% reported wanting teams of 2 to 3 midwives. But interestingly, you can see on the graph that 10% stated that the number doesn't matter to them and that it probably is more about the relationship, which is really interesting. And we have more data about that too. So we then looked at, again, Meg mentioned that we had this really high satisfaction rate. So we wanted to look at, are there things that change that satisfaction? And so we looked at, different aspects around continuity to see how it may or may not fluctuate. So first we looked at satisfaction for those who had a known midwife at the birth. And I can just show you here that 97% were satisfied with their care if they did have a known midwife at the birth, while among those who did not have a known midwife at the birth, still 83% were satisfied with their care. That may be a significant difference. We are going to explore that a little bit further, that in particular, that satisfaction related to the known midwife. We also looked at satisfaction related to the number of midwives that people met. So on this table, and this data is like hot off the press. We actually only got it, finished our recruitment a few weeks ago. So you are the first to see it, and how we kind of present it may change as we go along. So this table in particular, you can kind of ignore the column on the right with 7+ midwives met in care, although that group looks pretty satisfied, which is interesting. But when we look at the people in the other 2 groups, they are more than 90% satisfied, whether they met 1 to 3 midwives or 4 to 6 midwives. So it does look as if the number of midwives met in care doesn't really seem to have a huge relationship on there to people's satisfaction, which is also interesting. We've also started to look at how their satisfaction with the number of midwives that they met or the known midwife impact their birth outcomes. We don't have those tables to share today, but it looks like things like mode of birth, pain medication, induction of labor, the need for a consultation or transfer of care also does not impact satisfaction rates. Again, we wanted to look at satisfaction based on other characteristics. So this is a table related to place of birth. It may be slightly lower among those who gave birth at freestanding birth centers. So this is something we'll be exploring further as well.
So next, we wanted to understand how the participants defined and experienced continuity of care. So we asked a variety of questions about what aspects of continuity were the most important to them. So we asked questions like, how important is it to have a relationship? The continuity, like the management continuity, which is a consistent, coordinated approach on your team. Continuity of information, so feeling like their story is known to everybody. And specifically, we asked about the presence of a known caregiver at your birth, or care provider at your birth. So all of these scored as very or somewhat important by 97% of participants. So we asked participants to rank these core concepts of continuity in order of importance. So relationship, management of information, a relationship with my care provider. So this factor is the top choice. So as shown sort of by the high percentage here that you see of 53%. So it highlights that the most important participants prioritize a strong personal connection with their care provider above other aspects. So this suggests that building trust and rapport is crucial in midwifery care. A consistent approach to care, this factor sort of was more evenly split across the first, second, and third choices. It indicates that participants see that consistency in care is important, although it's not as highly prioritized as the relationship factor. So consistency likely supports a sense of reliability and trust. My story and values being known to everybody. So that was the lowest percentage picked as the first choice. So about 19.6%. So it's kind of showing that this factor is seen as meaningful, but it's a secondary priority. So while the participants appreciate having their personal stories and values acknowledged, it seems to enhance their experience kind of rather than define it.
I think we're almost at our time. So Meg, I think we should share this slide about when continuity matters, and then we can just say a few last points and wrap up.
Perfect. Yeah. So this is sort of when we kind of dug a little bit deeper here to look at what aspects of care were more important. So participants were asked, how important are the following aspects of care? And so having a care provider who offered and supported choice and autonomy, and someone they trusted and they could be their true selves with, that honest, authentic sort of space that's created was the highest, were the highest scoring answers at 97%. But you can see that accessibility, personalized care plans, having a strong relationship were also things that matter.
That's great. Thanks, Meg. And I also flashed up this slide about when continuity matters. And this was something we were really interested in. Like, are there times when having a known midwife matters more than others? And you can see these are the highest scoring answers for that. So at a home birth, when receiving bad news, during the first days postpartum, and if there were any emergencies or complications at the birth. So just tying this all together really briefly, I think the amazing thing is that we have really good evidence that continuity of care is alive and well in Ontario. And although anecdotally there's been some feeling that maybe we've kind of lost continuity or that's been jeopardized with different shared care models or the pandemic, I think it is still actually as strong as ever. And I think it's really impressive that we have such a high percentage of clients who have a known midwife at their birth. We did hear a lot from clients about this interconnection of relational, informational, and management continuity, and they seem to value all of those components. And I think we'll be able to continue to tease this apart to think about how do we support midwifery practices and midwives to really focus on all of those areas and support that in the ways that they work. And I think this also highlights that it is a multi-dimensional, complex kind of intersection of all of that. And I think that's been helpful for us to understand. Lastly, we do have some more bits of research coming. So we, as I said, this is very hot off the press. We are just about to finish our interviews where we hope to get a lot more depth of understanding about people's experiences, and we'll be able to share that. And then we also have planned a analysis of born data. So we're going to be looking at those measurements in the born data set that look at continuity. So again, presence of known midwife, total number of midwives met, and comparing that with birth outcomes across the province. So we'll be happy to share those results when they're available.
Wonderful. Thank you very much, Meg and Beth. We will all stay tuned for future presentations on the remaining findings from your research. So we do have some time still to be able to go through a few questions. If anybody wants to continue to pose those in our chat or through our Q&A, there is one that's come in here. From Jessica Jones, such an important topic as we all struggle to find sustainability in this profession. I'm wondering if you defined relationship in these results. Perhaps consistency in care and known story or values are wrapped up in what a client defines as valuable relationships with their care provider.
It's such a great question. Jessica, you are well aware of the limitations of survey data and how you phrase questions on surveys. So I don't remember what kind of definition we gave them specifically about relationship, but we were very careful about always breaking it down into those components in the way that we were asking the question. And we did ask questions around like elements of relationship and what that might mean. So around trust and around respect, and even just stuff around like listening and being present. So there were lots of domains related to the relationship aspect that we did look at. But this is certainly one of the areas that we hope to be able to get kind of a really rich understanding from our interview data, because I think it's important to hear from people about what does the relationship mean to them. And so Meg's been conducting a lot of those. I don't know if you have anything to add.
Yeah, really quickly, I would just say the interviews are really fascinating, if I'm being honest. And so I think there's a lot coming out. Again, it's not done yet, but there's definitely some themes around what does the relationship look like? How do you define it? And it's almost like the relationship is sort of a part of the approach that midwives take. And there's clear themes that are coming out around like what is a valuable approach. So that's not teased out yet, but it's coming. And I think we're gonna be really excited to share with you. The other thing is we forgot how important we are to people. I think that I forgot how much of an impact we can make on people's lives. And so that came out loud and clear, which is always something to keep in mind when we're busy.
Yes, it helps to fuel everybody in continuing in their roles. I'll pose just one more question before we wrap up here. What do you hope to explore out of the interviews that are being done that you haven't yet had an opportunity to mention today?
Well, a lot, but one of the things that we've been really mindful of throughout the conduct of this study is that we want to hear from people from different population groups, different identities, to see if there are people and experiences where continuity lands differently. So we were, as Meg kind of alluded to, but we weren't able to elaborate on, in our sampling of the survey participants, we tried really intentionally to find, geographic diversity. We also tried really carefully to find like ethnic diversity, people that identify as LGBTQIA, people who were unsatisfied with their care. And so what we did in the survey was ask people if they wanted to participate in an interview. We took kind of first come, first serve of that, but then we also sampled a second group of people for interviews who met some of those other criteria so that we could hear a bit more kind of from targeted groups. So in particular, like we found a few people who were unsatisfied. So we want to talk to those people to really understand like, okay, we have this big group of people who are super happy, but when you're not, what are some of the things that contribute to it? So in the interviews, I think we're hoping that we can really dive a bit more deeply into that. Those aspects of things that may impact people's experience of continuity.
Oh, that will be super fascinating to look at more. Thank you both again for this presentation, and this will conclude today's presentations on advancing midwifery research. We ask that you take a moment to fill out our survey with the QR code. Meg is just going to post that shortly. It is a short survey looking for feedback so we can continue improving our programming each year. There's also been a fund set up in the name of Jane Erdman, a wonderful midwife who has passed recently. Jane was a gift to the midwifery profession as a midwife and preceptor. If you wish to contribute in Jane's name, please check out the website at the Children's Health Foundation for the fund associated with her. These donations go towards supporting the midwifery department's work here in London so we can continue to innovate and support teaching, research, and clinical practice and free programming like this one today. Just a reminder that tomorrow's session will begin again at 12 noon and will highlight innovative clinical programming. We will be showcasing a review of the London Health Sciences Time Program, an EMCM showcase on midwives and collaborative healthcare partners, as well as a collaborative approach for healthcare partners and midwives meeting sexual and reproductive health needs for underserved communities. And finally, it will finish off with an Oak Valley Health Program showcase. With the rise in alternative models of care, we are so excited to share and learn from our participants about what innovative clinical programs midwives are offering in their community. Thank you for joining us today, and we look forward to seeing you all tomorrow.